And I'm very happy to introduce our 2024 speaker, Dr. Cynthia Brown. Dr. Brown completed her undergraduate degree in physical therapy from East Carolina University, and I learned she actually was in practice for about 10 years before she went to the University of North Carolina, Chapel Hill, to obtain her medical degree. At Yale, she then went to Yale, where she completed her internal medicine residency, did a chief residency, and then did a 3-year geriatric medicine fellowship. From there, she went on to University of Alabama, Birmingham, and then was there for a lot of her career, started there, and then served as division director for gerontology, geriatrics, and palliative care, as well as was the director for the UAB Center for Healthy Aging. She then changed her trajectory of her career in 2021, where she became chair of the Department of Internal Medicine at Louisiana State University Health Sciences Center. Her research interests have really combined the issues of low mobility and falls in the hospitalized older adult. And last night gave a wonderful community presentation where I learned something new. I need to change my terminology from falls prevention to safe mobility, which I think is a wonderful way to frame things. So please join me in welcoming Dr. Cynthia Brown.
I'm mic'd up. I'm good. So, hey, how is everybody? How is lunch? I usually come to Grand Rounds because they serve lunch. So delighted that you're all here. Thank you. Appreciate you being here. And I'm hoping that over the course of the next hour that you're going to learn some new things and that you're going to actually hear about some interesting initiatives that might be things that you are interested in spreading to your own hospital environments. So we're going to talk about developing the evidence for hospital mobility. And at this point, it's kind of a no-brainer because everybody understands that it's important. But I'm going to take you back a few years when I began my career, and it wasn't quite so obvious. So you've already heard no conflicts of interest, nobody's paying me money for anything, and we're not talking about off-label drugs. And you already saw the objectives. So let's move on to the good stuff. So we know that there are consequences of low mobility, and I'm going to use that term low mobility throughout this talk. And what I mean by that is bed rest or bed to chair activity only. So really it's not walking activity. And the reason that I've chosen to talk about it that way is because I started my life as a physical therapist. And so when my residents tell me, well, they're sitting up in bed or they're sitting on the side of the bed, I'm not impressed. It doesn't count. It's better than nothing, but if you're sitting in bed, but the bed's doing all the work, you're actually not doing much of anything. It's not until people are weight bearing that they actually get the benefit of being upright. And so that's what we're going for. And we know that all of these things listed here are associated with low mobility. And I do want to point out falls are associated with low mobility, even though it feels like they're at the opposite ends of the spectrum. So this is my favorite slide. This was a paper that was written by Morton Creditor back in 1995, published in the Annals. And what he showed was that, you can see at the top here, this is usual aging. And these are all the things that happen to us as we get older. So we see a decrease in muscle strength, and we'll talk more about that. We see bone density decreases. Our skin gets more fragile. So these are all changes that happen as we get older. But then we bring people into the hospital, and these are hazards of bed rest and hospitalization. And they include things like we immobilize you. not on purpose. It's not like people are writing bed rest orders anymore, but we put the bed rails up and we encourage you to call, don't fall, and nobody calls, so nobody gets out of bed. And we send your glasses and your hearing aids home because we don't want to lose them, right? But now I can't hear and I can't see. So we create an environment that actually makes bed rest easier, frankly. And that leads to those things that I showed you as geriatric syndromes, like we get deconditioning, falls, delirium, pressure injury, and functional incontinence, all related to being hospitalized and essentially being put on bed rest. So let's talk a minute about sarcopenia. So for those of you who didn't grow up with the term sarcopenia, it's age-related loss of muscle mass and strength. And this is a fairly new term, and I can tell you that the physiologists are still arguing about whether it ought to be sarcopenia or dynapenia or some other penia. Doesn't matter. I'm a geriatrician. What matters to me is that my older adults lose muscle mass, and we also see changes in the muscle fiber itself, that you see an increased infiltration of fat within the muscle tissue. And that is also common with aging. And all of that leads to a decline in the function of the muscle. It just doesn't work as good as it used to. That sarcopenia is associated with increased disability, gait and balance disorders. So all of these are related. So let's take a picture of what that looks like. So let me orient you. So at the top, I've got a female who's 27. I've got a male who's 25. And you'll notice, so this is a cross-cut through the thigh. So you can see the femur in the center. You can see the muscle tissue. And then the white around is the fat. And you'll notice, as is true in life, that the female has more fat than the male. It's terrible. It's not fair, but it's true. So this is a healthy 25 to 27-year-old. On the bottom, what you'll see is a female and a male. The female is 65, the male is 63. And you'll notice that the fat has increased, which we all learned in medical school, right? Fat goes up, lean muscle goes down. So that's what you're seeing here. And the muscle tissue is actually looking like marbled beef, right? You've got that fat running all through there. Well, that muscle is not going to work as good as the muscles that are in that top slide. And you might be thinking to yourself, they're just couch potatoes. They're not getting the exercise they need. That's the problem here. Actually, they are height and weight matched. So the young male and the older adult male are the same height, the same weight. It's not about being a couch potato. It's about what happens as we age. And these are 60-year-olds. No offense. I don't see 60 as old, especially as I get really close to it. It's not old anymore. Now 90 is old. And I'm betting when I get to be 85, 90 is not going to look all that old, right? So these are young, older adults. And yet these are the changes that you're seeing. So there has been one bed rest study that's been done on older adults. Just one. And this was done by Dr. Cordebian. And what they did was they took healthy, and let me say that again, healthy older adults, and they put them to bed for 10 days. And they were not allowed up. If they had to go to the bathroom, they actually put them in a wheelchair. They rolled them into the bathroom, let them do their business, and they rolled them back. All right. for 10 days. And look at what happened. They tested strength and they tested lean mass. So that's what you're seeing here. And I want you to notice on the p-value piece, let me get my little pointer over here, the p-values are all statistically significant. The thing I think is most important on this slide, though, is the change in lower extremity lean muscle mass. You'll see at the bottom that on average, this group of healthy older adults lost 6% of their lean muscle mass during that 10 days of bed rest. That's a heck of a loss, right? So coming into the hospital and being on bed rest 3, 5, 7 days is a huge deal because these were the healthy ones. I don't know about you, but in Louisiana, we don't put healthy people in the hospital, right? You got to be darn sick to come into our hospital. So you're not healthy. You've got inflammation. You've got lots of disease happening. So it's really important for us to understand that bed rest, low mobility absolutely makes a difference for our older adults. So back when I was first getting interested in this topic, which I hate to tell you was 20 years ago, I wondered about, well, how common is low mobility? And those of you who practice in our hospital environment know, yeah, it's pretty common. But we didn't have a way of studying it. So before 2005, there really wasn't a good way to measure hospital mobility. So one way that people actually did, so there were a couple of studies trying to look at mobility. So there was one where they looked at the physician's activity orders and went through and saw who had bed rest, who had ambulate TID or whatever, and they categorized that. So how do you think that went over? That's a good, right? Because we might say walk 3 times a day. Are we actually getting our patients walk 3 times a day? Not so much. There was another study that did a brief location of patients where literally they would walk along with a clipboard and say, in the bed, in the chair, oh, look, in the bathroom. Also not very effective because going to the bathroom and coming back, pretty brief. They missed a lot. There were nursing reports, which you can argue are good or not so good. And then there was direct observation of ambulation into the hallway. So in 2009, we published the first paper using accelerometers. And I don't want you to laugh, but these were our accelerometers. So we were beta testing these things. They were little boxes that were about 1/4 of an inch thick. And you can see a little bit bigger than the size of a quarter. And we attached them to the thigh and ankle of all of the patients that we were studying. And we were able to actually show for the first time what people were actually doing. So let me show you what people were doing. And isn't it amazing that now we all have devices all over the place to tell us what we're doing? But back in 2009, we didn't have that technology. So what we showed is that up here at the top is the amount of time, and this is the whole population of 50 people that we studied. This is how much time they spent lying in bed. And you'll see that 83% of their hospital stay was spent lying in bed. And then down here, you'll see that this is sitting, and you've got little peaks here. That's probably mealtime, but we don't know that for sure. And then this gray bar at the bottom here that doesn't really move, That's the amount of time people actually spent on their feet. And when we calculated that, it ended up being 43 minutes a day spent standing and walking out of a 24-hour period. And this is not 43 minutes of aerobic activity. This is shuffling to the bathroom, shuffling to the sink, going over to their closet to see where the nurse put their pants. This is the kind of activity that we're talking about. And oftentimes it was only in the room. It wasn't like they actually walked outside their rooms. This was stunning data. And really was the first time that we were able to capture what it is that our older adults are doing during hospitalization. And we created a model of the potential barriers. So why is it that our older adults aren't getting up? And so we created this model that is unfortunately very true. And there are sort of big buckets of reasons why people are not getting up out of bed. So some are patient related. So maybe they have altered mental status, or they have a lot of symptoms that were causing problems. Might be treatment related factors. So we've got them hooked up to an IV, a Foley catheter. They got oxygen on. Who the heck can get out of bed? There's too many tubes. There's institution related factors. And oftentimes this is around staffing, right? There's not enough people to actually help older adults get up and ambulate. The other is that the environment might encourage bed rest. And then there's attitudinal factors. So has anybody here taken care of the patient who believes that when they come to the hospital that it's the Ritz-Carlton and they expect breakfast, lunch, dinner to be served in bed, and they don't want to do anything while they're here because they're sick? Don't you know they're sick, right? We've created that expectation of hospitalization. So we did a study to actually explore these potential barriers, and we interviewed older adults, doctors, and nurses about their ideas around the barriers to hospital mobility. So a patient told us, I don't believe they're going to get me out of bed while I'm here. If I said I really needed to get out of bed, they try to do what you want them to do, but evidently they don't think that important. A nurse said, we try to encourage the doctors to order physical therapy because we don't have time to ambulate the patients in the hallway like the doctor expects. And we know that to be true. Our nurses are drowning in work. And then a doctor said, I think it's just that patients, when they're in the hospital, they feel they're supposed to be in bed and they're more comfortable there. And a lot of times they can see the TV better. And we chuckle a little, but I want you to think a minute about your hospital rooms. Where's the television? Right over the bed. And are there multiple chairs in the room so that if I had a guest, I could sit in the chair, they could sit in a chair? Not usually. There's usually one chair. So my company either has to sit in the chair or they have to sit in the bed. That's not going to happen, right? So while this is amusing, it's a little frustrating because we have created this environment. So when we looked at what people had to say, you can see these were the barriers that people talked about. And to orient you, the dark bar are what patients said, striped bar is what the nurses said, and the gray bar is what the physicians said. And so you can see that symptoms did come up. Weakness and pain absolutely were seen as potential barriers. There were medical reasons people thought of where people shouldn't be up out of bed, although I would argue that there aren't that many of those. There are just things that we've never allowed people to get up and walk when they have. There's worry about falls. And notice that every one of my physicians said they were worried about falls. Catheters, IVs, causing barriers. Lack of staff, absolutely. Interestingly, nurses were focused on lack of ambulatory devices. So they were aware of that. The docs, not so much. None of my docs talked about that. The other one that always is amusing is lack of patient motivation. You'll notice that none of the patients said they lacked motivation to get out of bed. All right. And in fact, one of the patients, when I sent her her transcript to review and make sure that it was correct, she sent it back to me with a whole diatribe on the back about the fact that she felt like the medical community did not communicate how important it was for older adults to get out of bed. And that if she had understood that it was important, she would have done it. So is it a lack of patient motivation, or is it that we haven't pushed it and explained it and encouraged it? So we then have to go on, if we're creating evidence, to demonstrate how frequent is low mobility and what are the outcomes, right? Because if there aren't any outcomes that are problematic, we're done, right? We don't have to do anything if there's nothing bad that happens. So we had data from just shy of 500 older adults. They were all over the age of 70. And I created a mobility scale based on nurse report. So that's the data that I had at the time. And I created that based on the degree of assistance that they needed and the number of times that the nurses documented that they transferred and ambulated, and created a scale that was low mobility. So that was bed rest, bed to chair only, intermediate, which meant they were up maybe a time or two, but needed significant help. And then high mobility, those people were up several times during the day and typically were walking on their own. And we looked at these adverse outcomes that are listed here. So you can see that any decline in activities of daily living, new institutionalization at discharge, and death were the three outcomes that we were looking at. And then there's a combined death or new institutionalization. That's because if you die, you can't go to the nursing home. So it's a way of fixing it statistically. But the important thing is that for low mobility, you can see they had a 5.6 times higher odds of having a decline in their mobility, in their ADL, if they had low mobility. And if they were intermediate, they still had a 2.5 higher odds of having a decline in ADL. So there was a dose-response relationship between the amount of mobility that they had and these adverse outcomes. And importantly, you'll see that we adjusted for what their ADLs were before they came in, their demographics, their Apache 2, Charlson Comorbidity Index, indicating severity of illness, as well as number of comorbidities, and whether or not they had an ICU or a CCU stay. So we really controlled for, as much as we could, the things that could potentially impact on these outcomes. So this was really nice evidence that mobility mattered and that we needed to pay attention to it. I'll also share that we did a study using data from the UAB study of aging to go beyond functional decline. So the UAB study of aging is a cohort of 1,000 older adults that were a random sample of Medicare beneficiaries in 5 counties in central Alabama, which is what you see there. And the study oversampled males, African Americans, and rural residents so that we had balanced samples. So 500 men, 500 women, 500 African American, 500 white, 500 rural, 500 city dwellers. And Tuscaloosa and Jefferson, so Jefferson County is where UAB is. Tuscaloosa is where that fairly good football team is. And then Pickens, Hale, and Bibb are rural counties in the surrounding area. And we measured something called life space. So life space is basically a measure of your community mobility. So how far away from your bedroom do you get, and how frequently do you get there? And the scores range between 0 and 120, and it asks how often you're able to do it and how much help you need from either another person or from equipment like walkers, canes, and the like. And this has been highly validated for both in-person and telephone access. There are hundreds of studies at this point using life space. If that's something of interest, you could look that up. But what we did was we looked at the cadre of people who had had a hospitalization. So 211 hospitalizations happened for 687 of these patients or older adults in the study over the first 4 years of the study. And anybody that died along the way or dropped out is not included. And we had 44 surgical admissions and 167 non-surgical admissions. So surgical admissions were total hips, total knees, open heart surgery, hip fracture repair, kind of the usual suspects for older adults. And the non-surgical admissions were COPD exacerbations, pneumonia, the usual. No COVID, because we didn't have COVID back then. And we did life space assessments every 6 months on these folks and used a very fancy multi-level change model to figure out what we call the trajectory of life space before and after hospitalization. So what I'm going to show you is a conglomeration of all of the data for all of these patients who had had hospitalizations. So what you will see is at the top, these were the surgical admissions. And on average, they were rocking around 65 on their life space. Anything above or around 60 is fine. You're getting out in the world just fine. The blue bar are the non-surgical admissions. And you can see they weren't quite as community out there, but not bad, not a huge difference. But then they had their hospitalization. And the surgical admissions actually had a 23-point decline in their life space. Anything more than 5 is the minimally clinically important difference in life space. So 23 points is huge. It's a huge difference. But you see the curve then goes not only back, but goes above where they were before they had their surgery. So the surgeons celebrated because that meant that the patients had their surgery and actually got better than they had been before. And the medicine doctors cried because what happened to the medicine patients is they only dropped 10 points, but look at that curve. There's no recovery. It's as if patients come into the hospital and something happens. And even though we fixed whatever was going on, they're still not back up to where they were even 2 years later. So this just highlights why we need to be paying attention to mobility. In terms of hospital-wide measurement, this also continues to be a problem, but I will share with you a couple of ways and scales that people have come up with as a way of trying to capture mobility. I am still waiting for someone to embed a GPS chip into the armband so that I know where every patient is and can track them. I'm sure there's some HIPAA violation in there, but that's really what we need, is to be able to follow what people are doing. But this is what we got for the time being. So you'll see the Johns Hopkins highest level of mobility scale is here. This is a nurse driven measure of mobility, and basically it asks the nurse to rate a patient from 1 to 8. 1 is that they laid in bed the whole time. The nurses are rock on with that one. They know exactly where the patient is there. 8 is that they walk 250 feet or more, which typically means walking around the unit. So they usually know what's going on there. Where they typically rate their patients is a 6. That's like the norm. The nurses will put 6. And that's frankly because they don't really know what's going on in the room, but that's what's happening in the room. We recently validated this other scale, which is called the Acute Care Mobility Assessment. I just got a paper from a friend who has translated it into Danish. And it basically asks the patient, did you get out of bed? Did you walk in the room? Did you walk in the hall? Did you walk off the unit? And how frequently did you do it? And what we have found is that it actually has a correlation with a step monitor of about 0.8. It's 0.83, which indicates a very high correlation. Anything above a 0.8 is considered excellent. I will say the Hopkins highest level of mobility with the step counter had a correlation of about 0.63. So not bad considering that it's the nurses who are measuring or documenting it. So what are our interventions? Lots of different quasi-experimental designs that have been done using aids, recreational therapy aids to help with mobility. There are nurse-driven models to try and encourage mobility. But most of these were quasi-experimental. There have been very few randomized controlled trials of mobility interventions. And I'm going to share with you the one that we did. And that was our UAB mobility program that was mobility by research aids. So these are normal people. They had no training except what Dr. Brown gave them. We practiced, and then I set them loose on the wards. So we recruited 100 older adults from the Birmingham VA. They weren't delirious, they weren't demented, and they were able to walk 2 weeks prior to admission. So those were our inclusion criteria. And they got randomly assigned to be either in the mobility program or usual care. And we had assessments done by blinded assessors and then 1 month telephone follow-up to see what happened afterwards. During the hospitalization, there were 3 falls, and this is what the IRB was freaked out about. But luckily for us, they were all in the usual care group. So my mobility program group didn't fall at all, in spite of the fact that we were getting them up and walking them. So please use that evidence, all right? 8 people didn't finish, and you can see the reasons they didn't finish: death, medical complications, and patient refusal. And this is what we did. So the mobility program was twice daily walks with somebody walking with you. If you needed a rolling walker, we brought one to you, practiced with you. Everybody got a folder, and this was both the usual care and the mobility program. And in the folder for the mobility program, we did daily motivational interviewing. We wrote goals. What are your goals? This, frankly, is what matters to the patient. That's really what we were trying to capture. So I would tell you about one veteran whose goal when he got home was he wanted to be able to walk his dog, Elvis, and he knew that he needed to walk in order to be able to get back to taking Elvis out for walks. In the usual care, they got these folders, but they just got friendly messages. Hey, great talking to you about Alabama football, or whatever it was. And they were told to track visitors while the mobility program group was to track how often they sat and walked. And this is what we found, so I won't spend much time here because you can pay attention over here and see that p-value-wise, there was no statistically significant difference between any of these. But they were an older group in their mid-70s. Not surprisingly, mostly men because it was the VA. They were relatively sick and in general looked a lot alike. And so here is their life space. Now, I've already told you 5 points matters and that we saw a 10-point decline in our other study. So on admission, you can see that in the mobility program group, this was their life space, was in the 50s, similar to the usual care group. No statistically significant difference between the two. But 1 month after hospitalization, you'll see that the mobility program group, their life space was almost the same. They'd had about a 1.5 drop in their life space, whereas the usual care group, lo and behold, had a 10-point drop, just like we saw in the other study with a totally different population of people. So for us, this just was the evidence that in a randomized controlled trial, when we get people up and we walk with them, when they go home, they are better in terms of their community mobility than they were if we left them alone in the hospital environment. So, Dr. Brown, how are we going to fix this in our hospital, right? That's the question that's in your head. Well, that's going to talk about culture change, because it is our culture to not allow people to get up and walk. So how do we fix that? So as we think about culture change, there are 3 elements that are critical to creating culture change. Team members have to be able to say out loud, what are we trying to do here? What is our goal? The team members need to understand the why. That's why I spent all of that time gathering evidence, because I needed to be able to demonstrate this is why it's important that we get people up out of bed. And then leaders have to define the role of their team members. We all need to know what our job is in order to make this happen. So for hospital mobility, nobody knows who's responsible for mobility, right? Nursing's thinking it's PT. PT's like, I can't walk all these people. There's only 4 of us on the team. How can we walk everybody? Physicians, we're not owning this, right? That's not my job, right? Maybe we can talk the medical student into walking somebody, but I'm not doing it. Our hospital culture encourages low mobility. Our environment encourages low mobility, and healthcare policy encourages low mobility. So let's walk through it. So ownership, I've already mentioned that there's way too few physical therapists, and it's not a skilled need. Oftentimes people just need somebody to say, come on, get up, let's go. They don't need the skills of a doctorate trained physical therapist. Nursing, they're drowning. They have so much on their plates. To add one more thing is probably unrealistic. And many of them report in studies by Barb King, a nurse PhD researcher in Wisconsin, that they're actually pretty uncomfortable walking many of our patients. In terms of family, we're going to have to educate the heck out of them. Volunteers, Hospital Elder Life Program has used volunteers quite successfully. So there are some possibilities there. And there's been a small study of transporters and actually training transporters to do it. The problem is that they have another job, transporting people. And so they often get pulled away. So Here are just some examples of how our environment encourages low mobility. And I mentioned the television screen. Like, I'd never leave bed if that was what I got to sit and watch, right? Breakfast, lunch, and dinner in bed. Hallways that are boring, nothing to see. And then you put me in one of those gowns. Now there's, you want to lose your pride, right? Put on a hospital gown with the back end open. Okay. So we have to re-envision what hospitals look like. We need to create spaces where people can walk that are interesting. One of the benefits of us at LSU is that you've heard of Charity Hospital. Charity Hospital closed during Katrina or after Katrina because of the flooding. And the state built a $1.2 million or $1 billion new hospital. And there's a law in Alabama or in Louisiana that says for every dollar that you spend, 1% has to go to local art. So if you come to our hospital, we have some of the most amazing artworks on every wall in every hallway. And so that is a reason to get up out of bed, is to walk down the hall and look at the artwork. So there are people who are working on this. What about global policies? So we have made fall prevention a mantra. Hospitals responded to CMS, who in 2008 said that fall should be a never event. Now, we have patients who are at home falling all over the place, but we bring them into our hospital and somehow they're not supposed to fall in our hospital. So what do we do to fix it? Call, don't fall. We educate patients about fall prevention. We identify them as fall risk, and pretty much all of them are at fall risk in the hospital. And then we put bed and chair alarms on them. And guess what? None of it works. Because what we need to be doing is encouraging them to get out of bed to maintain their strength. Another potential solution to this is to change our focus to safe mobility. There are projects that have been out through the Center for Medicare and Medicaid Innovation that actually pushed out safe mobility as a target, using it as a quality measure, and those were successful. And the other big area that is cutting edge right now in geriatrics are age-friendly health systems. And mobility is one of the 4 M's. So let's talk about age-friendly. So this slide shows you the 4 M's of an age-friendly health system. And it's just a framework for how we ought to be thinking as health systems about older adults and the care that we give to older adults. So it starts with what matters, because in the end, that is key to our care. This is what makes it patient-centered. If my vet wants to walk Elvis and that's what matters to him, then my goals need to be focused on getting him back to Elvis. Medications. Really thinking about, is the medication necessary? And if it's necessary, can we use age-friendly medications, not things like Benadryl, which is not age-friendly? How about mentation? Thinking about dementia, delirium, depression, and addressing that in our older adults. And then my personal favorite, mobility. There is a business case for age-friendly care, and you can see here it is outlined. We have evidence that it avoids the cost of poor quality care, that it allows delivery of care in a cost-effective manner, and that it actually can enhance revenue because of higher quality care. And as quality and quality metrics actually allow hospitals and sometimes even the physicians to get extra, to get bonus, because of the great quality that we're providing, this may be an incentive. It clearly helps with healthcare costs because you can reduce unwanted ICU care. If I don't want to be intubated, don't be intubating me, right? Just leave me on the floor or let me go home if that's what I want. We know addressing mentation and being aware of who is demented, that's going to predict who's going to get delirious in our hospital. And if you get delirious, length of stay goes up. I don't know about your hospital, but all my people are talking about is throughput, right? Get them in, get them out. And so those kinds of things reduce costs, which is good for the system. Now, I'm briefly going to touch on how to put an age-friendly health care system into place, only because I always get questions about that sounds overwhelming, and it is. But there is a recipe, and this is the recipe that the Institute for Healthcare Improvement shares with hospital systems who are interested in age-friendly care. And it starts by understanding where you are, what's going on in your particular hospital or on a particular unit. So it doesn't have to be the whole hospital. You can pick a unit. Figure out how are you going to try and initiate age-friendly care, design a workflow to deliver it, provide the care consistently, study it, and then improve it. And here's how you do that. Plan, do, study, act. Who's heard about plan, do, study, act, right? Absolutely. That's quality. That's how we improve our quality. And so what age-friendly does is utilizes those quality structures to take a pilot unit, test it out. What worked? What didn't work? Let's fix it. You fix it. You study it again. And you just keep doing it until you get it right. And when you got it right, then you move it to the next unit. And guess what? They got to do the whole same thing because every unit is different. But over time, you can actually spread age-friendly care literally across the whole healthcare system. So what do I want you to walk away with? Older adults are still spending a significant proportion of their hospital stay in bed. And every time we study this, this is true, even though we're trying hard to make it better. But many of the barriers to hospital mobility actually are modifiable. We just have to think outside the box a little bit in order to get them. We know that mobility programs work. They're safe, they're feasible, and they're efficacious. But in order to make all of this happen, we have to be willing to see culture change around mobility and integrate hospital mobility as a best practice for our hospital environment. With that, I'll stop and take questions. Yes.
Hi. We spoke yesterday, and I just have to give a shout out to my grandma who's 87. I'm going to visit her next week. She goes to the gym in her building 3 days a week, which is more than me. So if you need any motivation for any patients, you can totally give out a shout out to my gram. But I do have a related question. So you mentioned earlier in one of the studies, and I don't know that it needs to be specific to that study, but you showed the difference between low mobility and intermediate mobility. What are the ranges of activity that constitute each of those categories?
Great question. Okay. So because this was using data that was from the nurse report, we kind of used what we had. In this case, intermediate were people who probably got up either once or twice, but needed significant help from the nurse to actually do that activity. So they weren't independent. And that's probably the important part of that study, is the people that were independent were able to get up and move around on their own. And as long as we're encouraged to do so, they were in that high group. The middle group could do it, but not without significant help. The low group weren't either willing or able to do it at all. And so that's how those three categories came about. I think because we now have accelerometer data, there's probably ways that we could adjust that and come up with different numbers. Although I will tell you that in our most recent study, the majority of patients were still under 3,000 steps, even though we were encouraging mobility, et cetera. So people are still like, it's going to be very truncated compared to what happens out in the community. Thank you. Yes.
First of all, thank you. I have to admit, and please don't run me out of here, walking over, I said, mobility in the hospitalized patient. This is going to be riveting. Honestly, I found it riveting. It was the most practical and enlightening talk I've seen, honestly, in quite a while. So I really appreciate it. It's also very timely. We have an issue with VTEs over across the parking lot. And I noticed I didn't see like VTE in there as part of the geriatric syndromes. I didn't see SCDs as part of the problem, but think about how I can get the hospital motivated to participate in something like this. That's interesting. My question.
Yes.
I saw the 43-minute thing. I saw the get up and walk twice a day. If I was going to try to pitch to the hospital, here's what we have to do by hook or by crook, mobility tech PT. What's like the threshold to decrease, the loss in lean muscle mass? Is it, and use to walk? How far? How long? What do I need to do?
Awesome question. And one of our challenges, because I don't know that we actually know the answer. And frankly, it's going to be, you get whatever you can get out of them. And I think that proposing at least twice a day walks is probably reasonable, mostly because I'm a geriatrician, but I work on the general medicine wards at LSU with the residents. And when I think about, there's rounds in the mornings, you don't want them walking during rounds because I need to see them and I don't want to come back. It's all about me now. But then there's the going to X-ray, going to CT, going to MRI, like there's a lot of tests and stuff. And so figuring out a way to get them at least twice a day, I think that would help significantly in terms of loss of muscle mass, et cetera. The other part of it is that it helps people maintain their confidence in their ability to walk. And that's the other part. I think that thinking about 250 feet, a lap around the unit is perfectly reasonable. Most patients actually don't want to go farther because they're scared they're going to get lost. And they've told us that as well in qualitative work. So keeping it close, but also sharing messages, and this is what we as physicians need to be doing, sharing messages that it's okay. I want you to walk. I expect you to get up. There's going to be a person who comes in and says, get up. I want you to do that because that white coat still means a lot. And we can influence our patients to get themselves up and moving as well. So, but excellent question. I would love for you to call the NIH and tell them that I need to study this so that we can give people a very specific as to the amount. Absolutely. Thank you. Yes.
So that was a great talk. I completely agree with you that people should be moving. And I actually do talk to almost all my patients about moving, although I will say that there is less motivation among many. But I'm an infectious disease doctor, so it may just be my population that I'm saying. But, it's interesting to me that we're still talking about this, that this isn't usual practice. I heard a talk probably 15 years ago from someone at University of Chicago where they were doing daily, for people on ventilators, they were getting them out of bed and having them march in place. And there was huge improvement in outcomes. So it's crazy that, we have all this emphasis on all this other stuff, but we're not talking about what I think is probably the single most important thing that we could be doing for our patients. And why do you think there has been such poor uptake of something that's like very obvious?
Mm-hmm. Yeah. So I think it's a couple things. Some of it is, if you think about how long it takes us to take any discovery and actually bring it to the bedside, right? It takes us 20 years. We're just around 20 years right now, from the first study that I published demonstrating that it matters. So I think part of it is that inertia that happens. I think the other part is that it feels overwhelming to tackle it at a hospital level, particularly when everybody's scared to death about falls. And I do think that CMS set the work back significantly with the falls at a never event, even though the majority of hospitals do not lose money because of it. At UAB, I think we had 4 major, sort of catastrophic falls per year where they might have lost money. But because there is no incentive to get people up, there's nobody checking at discharge to see whether they are as functionally fit as they were when they came in. There's no incentive for us to change the culture. And so some of this is going to be around things like age-friendly healthcare, demonstrating that it saves money and provides better care, and we need quality to be hooked to function, not falls. That's going to be the key.
Excellent. Thank you so very much. And again, thank you so much, Dr. Brown, for being our 2024 Brock Institute-Glennan Center lecturer. I particularly want to thank Rob Goodman, who is the donor advisor for the Cook Fund of the Hampton Roads Community Foundation. And I just also want to acknowledge, of course, Dr. Castillo, as well as Dr. Bob Palmer, because when this Glennan Center Brock Institute lecture was born in 2015, when Dr. Palmer rolled out his Rolodex of who we wanted to bring, Dr. Brown was part of that. So it took a few years, but whoa, what an awesome opportunity, really worth the wait. And again, you all heard it, function over falls. So thank you so much. We had